Well, good afternoon. All right, good to be here, huh? Beautiful day today, yeah? At least much better inside here. I think I know many of you, but I don't know all of you. My name is Eric Schultz. I serve as President and CEO of Harvard Pilgrim Healthcare. And more importantly, I've been a member of the board of directors of the Kenneth Schwartz Center now for about a decade, I think. And certainly in my role as a health insurer executive, I spend a lot of my time on business activities and numbers and things like that. I love being part of this organization because it gives us a chance to focus on the things that all of us really are here for. And that is, how can we help healthcare be better, more connected to the human being, and produce better outcomes because we know the connection between the technical and the human piece. I've read through the bios of each of our finalists here, and we're so glad that you were able to find the time and come here this afternoon. Thank you. And you know, it was clear to me as I read through all of their stories, all of them, of course, went into their field to help people. And all of them are on a journey. And their journey is different, but it's all leading them in a very similar place, and it's the power of compassion. And it's the power of getting to know an individual human being in a clinical setting, and maybe not a clinical setting, and what it means. And maybe this might be an uncomfortable place for each of these people to be because they're so good about getting to know others and making them feel comfortable. And today, guys, we really want to get to know you better. And I say thank you for sharing your stories in advance, and we'll take it from there. So let's do this just to kick things off, shall we? What I'll do is I'll start here on my left and ask each individual if they would tell us who they are, what they do, where they do it. And just to start things, let's talk about, if you would, share with us how you see compassionate care at this stage of your career folding into your life and those of your patients. Sound good? All right, let's do it.
So my name is Rena Oddish. I'm a pulmonary and critical care physician at Henry Ford Hospital in Detroit. And I also am the medical director for care experience for our health system, which means I get to engage in wonderful communication initiatives for our care providers. My view of compassion at this point in my career is very personal. I think it truly depends on who you're engaging with, but that idea that you make the other person feel seen, that they know that whatever they're feeling, that you can reflect that back to them and hold it for them, and that the care is provided with that as the umbrella.
That's great. Thanks, Rena. Jonathan.
My name is Jonathan Bartels, and I'm from the University of Virginia Medical Center. I'm the palliative care liaison for the adult population at the hospital. And I also work with the School of Nursing for the Compassionate Care initiative that we have at UVA, and I help to facilitate training nurses and new nurses and graduate nurses and experienced healthcare providers in both resiliency and compassion. And I think you can't have one without the other. And if I were to define compassion for myself, it's the intent and want to relieve the suffering of another human being and lift them up. And coming from a space that you understand is equal footing. So it's a shared vulnerability that we have, and it's really it's really the space that I try to really inspire in the people I'm helping to train, is that shared vulnerability.
Thank you. And on the subject of equal footing, what did you do?
So I caused a Liz Frank ligament injury, and I like to tell people I am broke, but I'm not broken. And that's really
very good. Well, hope you made it through the security okay at the airport
and so
forth. All right, thanks. Victor.
I am Victor Fagan. I'm an LPN. I work at the University Drive VA Pittsburgh Hospital. I work in primary care. And so I see a lot of providers. I see a lot of veterans. I absolutely love the job that I have. And echoing what the other two folks said, the compassion is just that innate ability, as far as I see it, to connect with someone else and kind of feel what it is that they're feeling and kind of put them in a safer place or a more warm place where they're more comfortable with you and their situation that you can identify. Mm-hmm. And hopefully by the time you're finished with that person that you have in your space and your time, you have uplifted them to the point where, you know, maybe they were very sad or very angry when they came to you, but maybe now as they leave you, they are less angry or less sad, and they feel like they've been uplifted and that someone can help them, and they're going to get help, and they're going to be better. And I love it when I'm able to help someone feel that way. Mm-hmm. That's what I do. That's my job.
Yep, and I'm seeing everyone shaking their head up and down, really connecting with that. Thanks, Victor. Terry?
Hi, I'm Terry Inder. I'm a neonatologist, actually here at the Brigham and Women's Hospital Neonatal Intensive Care Unit, where I also lead the department to try and improve the care of our smallest patients. Mm-hmm. To me, compassionate care comes in many different levels and many different ways every day. To the babies, some who weigh less than a pound, it's the type of care and touch for every caregiver. To the families, it's embracing, supporting, understanding, and caring. Mm-hmm. And to the caregivers, who are sometimes the last piece of this, it's being able to be honest and share and support each other in some really sad and also some really happy moments.
You all have some very sad and happy moments, the extremes, right? Thanks, Terry. Lynn.
I'm Lynn McAtee Harris. I'm ICU nurse at Boulder Community Health in Boulder, Colorado. And I'm also the head of the Compassionate Care Committee, which it was a grassroots effort that I formed about 3 years ago. For me, compassionate care is three-tiered, and it's hard going last year because they've already taken all the good speaking points. But yeah, what we said. We based kind of our view of compassion on a book by Robin Youngson, who's actually a Kiwi. And he looks at it in three ways: compassion to your patient, which is patient-centered care, compassion to yourself, taking care of ourselves, and then compassion to your coworkers, which can mean your immediate coworkers and anyone else that works in the hospital. So that's kind of what our committee was designed to do. Every year we have a compassionate care symposium which addresses specific issues in compassionate care. And I think because it was a grassroots effort, it's really grown from the bottom and kind of blossomed out. And hopefully it'll become such a big part of our culture of our hospital that it'll survive after I leave. So that's my goal.
Based on our conversations last night, I'm sure it will. And last but not least, certainly, Alan.
Hi, my name's Alan Rosenthal, and I'm a pediatrician at the Cleveland Clinic. And I also am a facilitator in the communication course, a course that we teach on communication and empathy and compassion that we give to all 5,000 physicians at the Cleveland Clinic in Cleveland, in Florida, and in Abu Dhabi. And that's been very fulfilling. Compassionate care, to me, it's different depending on the interaction you have, but it's the realization that every time I walk in a room, I have an opportunity to make a difference, a chance to make a difference. And the realization that each encounter you have with I'm a pediatrician, so I'm dealing with children and parents and grandparents and whole families. No matter what interaction it is, the individual in the room or the individuals are vulnerable in some way. And it's up to me if I'm doing it the right way, to try to unlock that vulnerability and to try to replace it and to instill in them the confidence that, we're there with them, that we're doing it together. And so that's one of the things.
Thank you. So, Rena, I was struck when I read your bio and the story that you were trained as a physician and you went through a rather serious health crisis in your life, and it had a little bit of an impact. Can you share with us a little bit about that?
So, coincidentally, my illness was timed at the very end of my medical training, so it was the last day of my critical care fellowship. And I had, unbeknownst to me, a tumor in my liver that ruptured. I was 7 months pregnant, and these particular tumors tend to grow with pregnancy, which made it risky. And within the space of really 4 hours, went from being a physician to being a critically ill patient with kidney failure, liver failure. My blood wasn't clotting. I ended up having a stroke from the lack of blood flow and ended up on a ventilator. That night was really just catastrophic hemorrhage. And the recovery took a number of years, 5 surgeries, and a lot of recovery time. But what was so interesting to me was I really thought I was done with my education. I thought I knew what it meant to be sick, what it meant to take care of sick patients. I thought I knew how to be a physician. And that experience just disclosed to me that I still had everything to learn. I had no idea how vulnerable my patients were. I had no idea what it meant to take them off the floor to a test. They had just left and come back, and it was wonderful. I had results. And the sort of arrogance of that really struck me hard. I heard things said that I had said, like, "You really scared me," a physician would tell me. And I had told patients that. I thought I was expressing love, but it felt blamey suddenly when I was on the other side of it. And it really changed my view of how we should do things.
Mm-hmm. And so it changed your view. How did it change you?
It softened me a lot. I think
You do seem pretty soft and nice.
I am soft. We have confirmation.
We are in healthcare after all. It's okay to touch. For crying out loud, right? All right, please continue.
I think I had, I wanted to be a doctor from the time I was 5 years old. My brother had this fatal swelling of the airway called epiglottitis, and I remember my mom calling the pediatrician, and he distilled through her, frantic conversation what was happening. And I thought that vision of medicine, that you could listen and use that knowledge to heal, was just the most beautiful job description I could imagine. And I venerated medicine. It was all I aspired to be. And what I realized was that, medicine can't heal without that compassionate connection, that the science is only one side of it, that the drugs that we have and the treatments are all meaningless if they don't happen in a space of connection.
Mm-hmm. So true. Jonathan, let's move to you. In reading your stories, one of the many things that stood out was where you talked about the power of the pause. Can you tell us what that is, how
Sure.
it came about?
So I was working as a ER trauma nurse at the time, and I had just gotten off a retreat with Joan Halifax, who had done a lot of work with Being with Dying as her course. And she had given a mandate after we left, and she said, you're going to take everything you've learned and you need to do something with it. And the retreat itself had a lot of people in palliative care at the time or hospice. And I thought to myself, boy, I'm going into trauma. I'm going into ER. Mm-hmm. And what am I going to do in this environment? And how am I going to make a difference? And I'd seen a chaplain one day stop a room after really horrific trauma and did a prayer. And I thought that was really kind of cool, mm-hmm. that she was able to stop. She was able to be brave and stop a whole room. And I said, prior to even me being a nurse, I was a graduate student in comparative religion. And so I'd studied anthropology, and I knew death is a rite of passage. I knew we had lost something, and I saw what she had done, and I started to implement my own style of it, but using the power of silence and asking the room after a patient dies to hold that space in silence. And that space in silence would allow for a Muslim, a Jew, a Christian, an atheist, an agnostic to hold that space together in a shared experience, but hold it also in the silence. That was almost the opposite of Tower of Babel, but it was something that everyone shared in the honoring of both the patient and the staff and the family. And I did it, I implemented it, and it kind of, people started replicating it because they saw something in it.
Yeah.
And that's really how it spread. I was encouraged to write about it, and I didn't want to write about it. And I felt that it was a Captain Obvious moment. Doesn't everyone stop and do this? And someone said, no, they don't. And I said, all right, I'll write about it. And I wrote about it. And after writing about it, it encouraged others and gave people permission. And it made a paradigm shift across the country and across the world for people to now have permission to do that and bring that rite of passage and honoring and self-care. Even though it's not something that will cure all, it's not a silver bullet, but it's a start. And so it was cool.
It is cool, and it's also, I mean, we live in a day where religion is viewed so differently by all of us, right? And some with respect and some without respect. So how do you deal with such diverse views of religion and faith, or lack thereof, in this moment? What are the words you use?
Well, the languaging, you're pointing out a very important part, at least for me, is the languaging. And I usually, it's not humanistic language, but it sort of is. And it's, I usually will say something to the effect of, before we leave the room, could we take a moment to honor this patient? Before they came in this room, they were alive, they were loved by others, they affected others' lives, and now they're not here. So in our own way and in silence, let's hold that space and just take 30 seconds, a minute to do. Surgeons, 30 seconds, medicine docs, usually a minute.
Is that all? Do you have a comment on that, Ron?
By the way, I'm soft as well.
Except for his ankle. While you've got the stage here, there was another interesting story. I worked in a nursing home in housekeeping as a teenager, and you worked in a hospital, or a nursing home, was it?
It was.
Tell us the story. When you were 18.
Oh, I was 18.
This is going to make you seem not so nice.
No, not at all. So I was 18, a typical 18-year-old. And 18-year-olds are brash, and 18-year-old boys are even more brash. And, I was kind of a punk, literally. But I was growing up in a hospital, working as an orderly in the hospital. It was a really busy day. And so I didn't know what I was doing as much as what I needed to do. And I needed to answer all the call lights. So I started at one end of the hospital and worked my way down. And so by the time I got, and in one place, a little old lady's dangling off a bed like a bungee jumper, and I'm getting her back in. Other places I'm doing, buffing people's pillows and getting urinals, doing all the stuff you do as an orderly. And I finally get to this room, and this guy's in the bathroom. And he's my age now, I'm 49. And he was 49, I was 18. And I walked in and he yelled at me and said, "Where the hell have you been? I've been sitting on this call light for an hour, and where have you been?" And I kind of, as a brash 18-year-old, I was like, "Oh no, dude, you are not the only patient in this hospital. You are one of many, and I was working my way to get to you." And a nurse overheard the conversation and came and helped me help the guy up off the commode and into the bed. She brought me into the hallway, and she said, "I don't think you realize that guy that you just had that interaction with was just told that he has 3 months or less to live. He's 49. He's a father. He has kids. And he needed your help. And it's not about you. And so that was my indoctrination into compassion and empathy that really made a shift in my life. It was a memory I hold true to every day that I work.
Yeah. And that guy, if he's looking at you now, he's thankful. It was a learning process, and whoever advised you to the learning moment.
Right.
But I appreciate you sharing that.
Yeah.
You really are a good guy, though.
Thanks,
despite-
brother.
You know.
And I am soft.
We got to know each other last night at a dinner, so it really is fun. So, Victor, the first thing I want to say to you, you're a veteran, I understand, and we thank you for your service to our country, and frankly, to all the veterans in the room here. Thank you, recent Veterans Day. And I'm really curious to understand, working as an LPN in the primary care division in a veterans hospital, give me a perspective of, from a veteran to a veteran, frankly. What's unique about that? And how do you deal with that?
Well, what the unique thing from a perspective of a veteran to a veteran is you kind of been there and done that. And so in having conversations with some of our veterans sometimes, we can get really deep into some stuff. Some of our guys and ladies have very serious issues. And so we at the VA in primary care, we kind of ascribe to a holistic approach to treating that veteran. In primary care, we also have psychiatrists and psychologists. So if we need to send someone there now, then they are right there right now. So let's kind of get them that help. A lot of our veterans, we do have a homeless population, and sometimes we're kind of reluctant to come in and get help because for whatever reason, they did not feel like, whether it was at the VA or some other place, that they didn't get the appropriate care, or folks didn't care about them or just forgot about them. When they come into my VA, from the door to your appointment, to your provider, to back out the door, we try to make sure that you are seen appropriately, and we try to make sure that you get that medical attention that you need, whether it's something socially, something clinical, or something otherwise. We don't want you to go until we have fixed you as best that we can fix you that day. Even if we have to send you to the emergency room or direct admit to the floor, before you go, we want you to know that we're going to be here for you, and we're going to fix you as best as we can possibly get you fixed that day. And if we can't get you completely fixed that day, you need to come back. We're going to repeat that process all over again, as many times as it takes until we get you fixed. As much as you are fixable. You know what I mean?
Yep.
I mean, some folks are not fixable. They have some conditions that, manifestly will not be corrected at some point. And so the end result is, this is what it is. But at the same time, we still need to see them and treat them and make sure that you are here amongst your friends and your peers, and along this journey we will go with you whatever way, whatever path it is. We will be with you step by step.
Kind of meet them where they're at,
right,
and understand where they'll let you go with them.
Exactly.
Yeah.
Exactly.
You told me an interesting story a little while ago about an ugly wall. Why don't you tell us about what happened there?
So here at the VA hospital in Pittsburgh, our waiting room, a little larger than this, and it is absolutely horrifically ugly. It's just as plain can be.
Mm-hmm.
And up on the walls are some very large pictures of just stuff, flowers or whatever the heck it is,
Mm-hmm.
which I'm pretty sure the VA paid way too much money for. And I'm looking at these pictures one day and I'm like, oh my God, we can do better than this.
Mm-hmm.
And so I thought, well, perhaps we can replace these pictures with pictures of my veterans and their stories. For an example, say you were drafted
Mm-hmm.
and you served in Vietnam,
Mm-hmm.
and during one of the battles you were injured, and because the result of that injury you were awarded the Purple Heart. So now your story is, I served in Vietnam.
Mm-hmm.
I was injured. This is my story. This is what occurred.
Yeah.
And your picture and your story goes inside that glass wall for other
Very cool.
veterans, families, other caregivers, whoever's down there can see that story
Mm-hmm.
and say, this is how and this is why we are the United States of America.
Mm-hmm.
Least we forget, this is why we are here. This is why we do what we do,
Mm-hmm.
because of what those folks did. And that was the whole thing. That's all I wanted to do.
That is so cool. And this is a primary care center, so you have a number of your patients coming in multiple times, let's say in a given year. I'm curious, when they come in, how do people react to the wall? What do they do?
It's not there yet. Committees have been formed.
Mm-hmm.
It's going to be built.
Yep.
And see, I just wanted something simple.
Mm-hmm.
Just put some pictures with some stories, veterans in their uniform if they have it, and just move on.
Mm-hmm.
Just put as many people in there as I possibly could.
Yep.
Well,
You got a freaking committee.
You do work for the government, Victor.
exactly. So we had to form a committee. And then we had to have everybody in the hospital somehow connected to this committee. We needed the grounds people, we needed interior design, we needed, space or whatever the heck it
Yeah.
was.
Mm-hmm.
So something simple has morphed into this hospital-wide thing. So a few months down the road, somewhere, I guess, we're going to have all this stuff installed, and the pictures are going to go up, and it's going to be a glass case enclosure with uniforms and stories and all this other kind of stuff.
That's really great.
So I think that's really, great. It kind of just, became bigger than me, and
Well,
that's okay.
That's a compliment.
That's okay.
I mean, having a committee is not really fun, but that's a compliment.
Right.
What are you going to call it? You
The
need a
Heroes
committee.
Wall of Fame.
Oh, so you didn't need a committee for that.
No, I came up with it all by myself.
That's great. That's great.
The Heroes Wall of Fame.
I think it's terrific. Thanks
Thank
for
you.
sharing that.
Thank you.
Now, Terry, last night when we were having dinner, I didn't notice a cast on your arm.
It's hiding under here.
You thought it was hiding until I said. Anyway, I digress. All right, so you know what struck me last night, Terry, was the story you were sharing about one of the babies being actually less than a pound, and it's just remarkable what you can do these days. But here's where I struggle. When I think about compassionate care, I can intuitively understand creating a connection with another human on a cognitive level. I can communicate and all that. You're dealing with little babies, little beings. How do you do it?
So we have the privilege of doing it with the babies, with the families so we take care of a village when we take care of a patient, like all of us do, I think. But we underestimate how much babies really feel, know, and how critical it is, because the experiences they have are during this really critical period of brain development. And unlike any other period of life, those experiences really influence brain development, brain connections, and are there for the rest of their lives. And interestingly, when I started in medicine, I really thought it was going to be the drugs and the type of ventilator we had and the type of equipment and all these amazing advances we were making in our field, which have contributed to survival. But the last 5 years of our work in particular have shown that it's the experiences of the baby. And in particular, and I even hate to admit this, but what we do in my field at the moment is at the birth of a premature baby or a sick baby, we take a baby away from their mother. We place them in a plastic box. It was actually named an isolette to isolate the baby from the mother. We have to do a number of procedures that are uncomfortable or painful for the baby. We separate them from any experiences of nurturing, of
As
human
soon as
love.
they're born.
Right. And then sometimes we even think, and I mean, if you go to China, even now, most parents are only allowed to visit, they're regarded as visitors, for 10 minutes a day to be able to be with their babies. So their babies only have that experience of human love and nurturing for that period. And everything that we're finding now is that these negative experiences and absence of positive experiences are absolutely critical to human brain development and to forming the foundation for all of the types of behaviours we want for the rest of our lives. And it's by term. It's remarkable that a healthy term baby has the areas of the brain for facial recognition all fully formed, even before they've seen a face. They have the areas for language all fully developed. And people say, but they haven't heard anything, but they have. They've heard their mother's voice. And so these things and these elements of nurturing and human experience to be shared are the things that we have learnt now we have to reinstill into our environment. We have to value them more than the drug. And at the same time, recognise for our parents the trauma associated with the whole experience. To be separated from your infant, to be disempowered as a parent, to not understand your role. They leave scars that, I have parents who are 10, even 20 years out who can't still walk into a hospital because of the trauma they've carried with them for all of these years, because we don't even legitimize it. We don't say to the families, we say, how are you? But we don't really say, how are you? And we can only imagine what you're going through and how can I make a difference today to get you through today. And you know what? We need to have parent mental health and emotional well-being support in our units. We need to legitimise the fact that some of the experiences are extraordinarily difficult to come through, and that as well is going to influence the long-term outcomes of our babies and families. So I hope to move the needle from survival to be able to think about the real influences on the nature of what we are having the privilege to watch, which is human development, and the whole village around that little person as they leave our environment and spend the rest of their lives, because we have the privilege of really being at the start of someone's 70 or 80 year journey. And we want to make sure it's as good as it can be.
So help us understand. Let's create a scenario then. Let's say you have a premature baby born who's a pound or 2 pounds or 3 pounds, very small. As a non-clinician, I'm thinking they're in a very special crib, unit, all these things tied up to them. And you're talking about the power and importance of human touch connection for these little ones for brain development. How do you deal with the fact that they're so small and you're trying to control things like infection and all that, but also involve the parents in a more traditional way?
So it's really a shift in mindset from the fact that parents are visitors to parents as partners. And, there's no one who loves or cares for that baby more than their parent. And how do we embrace that, partner with them to be a member of the care team, not just a visitor to come and see their baby. And so it's a paradigm shift from thinking that the professional is the one who knows the best to saying, actually, we're just here as someone who has got experiences to share with you in every decision that we make together for your baby. It's your baby. Because this is
that
where...
really empowers them or makes them feel in control.
There are some units internationally where the baby, even a 500 gram or less baby, will be transported up, not in an incubator, but on the father's front.
No kidding.
That the babies will... many hospitals don't even record how often parents are present and holding, we call it skin to skin or kangaroo care. Fond of kangaroos, so kangaroo care. But, that this has been shown in an Israeli study to have impact on IQ 10 years after discharge. There's nothing I do with a medicine that has an impact 10 years later. But 1 hour a day of human mother and baby or father and baby connection has that.
Wow.
So it just talks to the power of what this incredible belief system of human connection, human caring, and the influence it has on not just well-being, but real outcomes.
Yeah, and it ties in, I'm sure most of us in here have read Kenneth Schwartz' op-ed piece, and I feel like you're taking his words that I've read. I never knew Ken, but reading his piece and the power of the human touch and the connection, complemented by the technology and all the medicines, but without that, thanks for sharing that.
It used to be in the ICU that you would only be allowed to visit 5 minutes every couple hours and whatever. We've gone, and I'm sure this is nationwide as well, we've gone to 24/7 so people can stay as much as we want. And I'm sure if they did studies, with adults, it's the same way. The touch used to be if you had a critically ill patient and we're monitoring their ICP and they're on a ventilator and we don't want them touched. And now we encourage, patients or families to come in, hold their hand, let them know you're here, talk to them, it's okay, rub their feet, whatever. The more touch, and I feel like it's really important for healing of adults as well.
So let's go with that then,
babies.
Lynn. So ICU nurse, I think of ICU as the most impersonal, lots of beeping, mean nurses, just kidding. My mom's a nurse, sister's a nurse. But Lynn, talk a little bit more, help us understand where this compassionate care fits into the ICU, and love to hear a little bit more about what you've done at the hospital around the symposium.
Right. I was listening to Jonathan's 18-year-old story, and I had something similar when I was a little younger. I remember a really sick patient. I was in charge. One of the nurses ran out and said, "Oh my gosh, something's going on in the room. I can't figure the pacemaker out, and the ventilator is beeping, whatever." So I thought, and put my cape on, ran into the room, and the family's standing there and watching everything, and their loved one is really sick, and I adjust the pacemaker, I adjust the ventilator, I do this, and I tell the nurse, in a strange language that the patient or the family can't possibly understand in medical terms, and this is what happened, this is what you need to do, And I thought, they are going to be so impressed. And I'm just the nurse of the year, and I turn around, and the look on their faces, it was just horrifying, and it made me feel so terrible that I had gone in, focused completely on the machines, didn't even look at the patient in the bed, and did all this thinking that I'm saving the day. But in fact, I didn't make it worse. The patient was fine, but I said nothing to the family. And it was that moment sticks in my mind as the moment that I realized that there's got to be something more than machines around here and adjusting knobs. And so I immediately went and sat down with the family and explained to them what we had done and why we did it and what was happening and that it was fine now. And a lot of times, and I do love machines, and I This is why I went into the ICU, and my favorite patients are the ones, machines and bells and whistles, but it's so much more than that now. Mm-hmm. And when I get focused on the machines, I try to remember that day and how terrible it was to feel that I had let that family down and I had let their loved one down by being so non-compassionate. Mm-hmm. It was, I feel really bad about that. But you asked about the symposium.
Yeah.
We had just moved into our new facility, which was beautiful, and all the greatest machines and the wonderful rooms and, patient beds, and everything was bright and shiny. And we had left our old falling down hospital behind, and it was sad. It's like moving from your little tiny house, which you loved, and you were cozy, and you loved everything about it. You knew every little crack in the wall, and we were in this wonderful facility, but no one was happy. We were so stressed and burnt out. We had an incredibly sick ICU at the time that we moved, and no one knew where anything was. It was beyond. People were quitting. No one had enough money. No one had enough time. It was a horrible situation. Mm-hmm. And at the time, one of my friends I had formed a book club at work with nurses and doctors, and my friend, who was a cardiologist, gave me a book to read, and it was from I don't want to say Kiwi, a New Zealand anesthesiologist, and it was called Time to Care. Mm-hmm. And it was about compassionate care. And I thought, wow, this is amazing. Mm-hmm. This is something that we need. We need this so desperately right now. Mm-hmm. We're pretty good with our patients, but we are falling apart as a unit. We're biting each other's heads off, and we can't take care of our patients if we are experiencing this kind of burnout and this stress. So my cardiologist friend and I devised the symposium, an all-day-long symposium, where we had each one of us spoke, and we had another guest speaker about compassionate care. And it was kind of the first time that I don't know, I feel like it was the first time that a lot of people had heard about it, and it was enlightening.
Did you have a committee to do this?
No.
Just checking. Victor.
Well, that's funny because people offered to help, but it was just Jignesh and myself. It was like, no, this is, we had an idea of what we wanted and what we needed.
Yeah.
And we did it specifically for anyone involved in the ICU. So we had doctors, nurses, physical therapy, occupational, chaplains, pharmacists, everyone came. There were about 35 people that came. Yeah. And we did breakout sessions on mindfulness, on communication, on patient-centered communication, on empathy, on gratitude, meditation. So we had all these different breakout sessions that we could go to. And then we came back in the end of the day and said, where do we go from here? How can we carry this forward and keep this going all the time in the hospital? So, so then we formed a committee after that.
A very efficient committee, I'm sure.
Yeah.
But, I get the doctors, the nurses, and some of the other clinicians. Who else was part of the original planning? Did you say maintenance, housekeeping?
Oh, that was this year.
Yeah.
And our committee has grown. So my goal was to have representation from every department in the hospital. So for the clinics, from EVS, we got one of our housekeepers who doesn't speak English very well, but she really wanted to be on the committee. So she joined with the Spanish interpreter. So we have that representation, which is awesome. And they actually spoke for this last symposium and did a breakout presentation on Spanish interpretation in different English as second language. Yeah. So that was cool. And I've said to a lot of you already that my goal before I retire, hopefully, is to make it part of our culture and make compassion part of the culture, where it has a name, it lives in a place in our hospital that will always be there.
Yeah, I think it's great that you just did that. You were inspired by a book, which is great. Many of us are, but you took action from what you learned. Well done. So, Alan, I remember reading a number of things also in your bio. One of the things that struck me early on is that you talk about compassion needing. We need it now more than ever. We talk about the healthcare system. You and I chatted a bit about this last night. But talk about why you say that compassion is needed now more than ever.
So it's such a relevant question, and it really is based on what used to be to some extent and what is now. So just to divert a little bit, when I was growing up, my father, who passed away 20 years ago, was an internist, and he had a private practice, and he taught at the medical school. And when I was growing up, he made house calls. I remember the phone ringing at 3 o'clock in the morning, and he left. He made house calls. But on Sunday mornings, we had season tickets to the Cleveland Browns games, and that's when they used to win some games. now I would say, no thanks, Dad, I have something else to do. But he would take me, and he would make house calls on the way to the game. We'd have time for one or two, and I would go with him. And he'd have his black bag, and he'd make a house call, and I'd sit. And what was the interesting thing to me, when the house call was done, we didn't leave the house.
You did?
They insisted that he sit down at the table. I sit down with him. They gave me milk and cookies, or I don't remember exactly. He'd have a cup of coffee, and they would just talk. And he was part of the family. And my father didn't say much to me about that kind of stuff, but I saw the way they looked at him and the compassion he showed just being there for them, treating them not just as a patient, but that they were people with lives, with purposes, with things that they did, and they included him in their circle. And it didn't just happen once. It happened just about every time we made it. I'd go with him. And so that was one of the things that made a profound influence on me, the fact that it's relationship-centered healthcare.
Yeah.
You're in it with the family, with the person. And translate to 2017, 2018 coming up, the system is really in crisis, if you really think about it. Not so much at all with the people that we're interacting with on the stage, all of whom are just absolutely phenomenal. But when you look at medicine now, it's changing. We're faced with a system where we have a ton of metrics thrust upon us. Healthcare is changing. We're being asked, there's a million governmental regulations thrust upon us. We're asked to see more patients in less time.
Insurance regulations.
Insurance regulations.
They're the worst.
In private practice, I spent half the day on the phone with the insurance company because they would deny the treatment or the medication. Just so little things that were interfering in our ability. And as a result of all this, it's disheartened many providers. It's incredible. People are depressed, they're distressed, and they're not enjoying it. And in fact, I can't tell you how many people I will hear, and I'm sure that all of you could echo this. I would never tell my kids to go into medicine. You hear colleagues say that, whereas when I was growing up, that's all I ever wanted to do. So what's so passionate for me is the fact that I want to just yell at these people. No, it doesn't have to be like this, folks. It's more important now than it ever was to show compassion, to show empathy, because when you think about it, why did all of us go into medicine in the first place? Everybody that went into it with a very idealistic thinking that they want to help people. Everybody had the right mindset and still has it. And it's such a shame to me to see it destroyed and decreased in so many cases. So we're fighting a system that to a great extent we can't control. We can't control the regulations. We can't control the healthcare plan. They can't even decide in Washington what the heck they want to do with it. But we can't control so many things. But we can control the fact that we have the ability to interact with patients and families in a compassionate way, to show empathy, and to show everybody why it is that we went into medicine. And to not lose that ability, that gift that we had. It's a real gift to be able to impact another person. And it's such a shame to me to see that gift lost in so many cases. So I feel like we up here, we're fighting a big battle because the odds are stacked against us in many ways, but we can't quit. we have to really dig in and work harder, and we can make a difference.
Yeah. And you were in private practice, I think, for a number of years before you joined the Cleveland Clinic.
Correct.
And it was interesting to watch Alan last night at dinner, because he gets his iPhone out, and I was doing all I could just to keep it in my pocket. But what I was struck by is you're a private practice physician who is pushing the boundaries within the structure of a group practice environment. Tell the group some of the things you do.
I would, I'm
I
a
don't wanna
private
get you in
practice
trouble.
guy, and I mean, if Dr. Cosgrove is here at this, I'm probably in pretty big trouble here. But
It's just us in the room.
the Cleveland Clinic is a fantastic place to practice medicine. I'm working with some of the most brilliant colleagues that, I can't even hold a candle to in terms of knowledge base. They're that bright and they're that good. But you're with a big system, and there's a lot of rules and regulations and things such as that. So one of the things that I do, and I try to bring as much of my private practice as I can to the Cleveland Clinic, and I get a little bit of pushback once in a while. But one of the things I do that I'm sure they wouldn't be too thrilled with, but I refuse to compromise this, is I give a lot of patients my cell phone number, because number one, it's impossible to get through with the central scheduling at a big institution. And so I give people my number, and it's amazing. They don't disrespect it and they don't abuse it. But, as you saw last night, I had several patients that were texting me and calling me, during the dinner, asking what they should do, texting me a picture of a rash, what is it? So,
well, you know what I was struck by?
and-
Alan, the emoji that you put, that smiley face with the teeth, like you were scared or something?
Yeah.
No, I'm kidding.
So, I try, what I try to do, I try to bring my private practice, what I consider to be assets, into this big group practice setting. And as I said, it works well in terms of my patient satisfaction ratings and things like that. But again, it's not really the thing that they want me to do.
Right.
So, it's you got to do it the way you see it sometimes.
That's right. We won't say anything.
I think if I was just starting out in practice, I probably wouldn't do that. But the fact that I've been in a while,
What are they going to do, right?
yeah, what are they going to do?
Yeah. You're a pediatrician. We need primary care.
Correct.
It's easier to ask for forgiveness than permission.
What was that, Lynn?
It's easier to ask for forgiveness than permission.
That's right. Now, do we have microphones set up for questions? I wanted to let you all know that if any of you have questions for these great individuals up here, we've got plenty more on my book. Yes.
Hi, thank you so much. It's very inspiring to hear every one of you speak. You just mentioned how fabulous a place the Cleveland Clinic is. And then you said, it's not what they want me to do, but I do it anyway. Why would a place as fabulous as the Cleveland Clinic not want you to do something as fabulous as what you do?
I don't know. Yeah, it's a good question, and I obviously pushed it out. I'll give you another little story of something I did, which I thought was the right thing to do, but sometimes I put myself out there a little bit when I do this. I had a patient, a new patient that came in 2.5 years ago. She was an 7-year-old little girl, wasn't my patient, had seen several other physicians in the community, but she came in with severe headaches. And they were the type of things that when I took a history, that I knew this wasn't a very good situation. They were waking her up at night. They were horribly painful. In fact, one of the most traumatic things I saw, I actually left the exam room for a minute because her father was holding her. And think of it being a parent or a grandparent, and I knew something wasn't good about this, but she said to him, "Please, Daddy, make this pain go away." And I walked into my office and I just had tears coming down. And my nurse, who was my age and my generation, and the most wonderful nurse, but she said to me, I'll never forget, she goes, "Would you toughen up and get back in there?" And it was so
like
true.
A true nurse.
So anyway, I knew, so I sent this patient for an x-ray. Okay, I called the radiologist, and Unfortunately, the call came back to me about an hour later that there's a mass. This patient has a brain tumor. And this it was exactly 16 and a half miles away, because I'll tell you why that's important. But the radiologist said, all right, so should I break the news to them and we'll get them transferred to the pediatric intensive care unit. This is the protocol. We'll tell them, we'll get everything. I said, no. I said, I'll come and tell them. And they go, you'll what? I said, I'll come and tell them. So the radiologist, so I said, just tell them to sit in the room. I'll be there in about 25 minutes. And I remember it's 1 o'clock in the afternoon, and I have, I think, 14 patients still scheduled. So I said to my nurse, cancel my schedule. I'm going to tell the patient. She goes, Dr. Rosenthal, you can't do that. The clinic doesn't allow that. They'll fire you. I said, cancel my patients. I'll be back as soon as I can. And so I left, and I went, driving along to tell the family, with no idea what I'm going to say, because so needless to say, I went and broke the news myself to the family, and that's a whole other story about how the concept of breaking bad news. But sometimes you got to put yourself out there, and you have to do what you think is right. And I don't know if I risked it. I'm still working there, so they didn't fire me, but. Yeah, look where I'm sitting. Yeah, that's a great point. But
stories are so powerful because they give us not only a sense of who you all are, and you're all very special people. It also helps to instruct us how compassion is so powerful in care delivery. And you've all had experiences that have influenced you, but I wonder if any of you would be willing to tell some stories similar to how Alan has, to give us a different dimension of you. And we don't have to go down the line, but if anyone thinks of anything that comes to mind.
Well, I think the thing that strikes me literally is that people can spot a phony before they ever see you. It's like, oh no. Now this person is just here to get the paycheck and then go on about their business. They're so easily spotted. And in our business, if you don't have that empathy for your patient, if you cannot see it from their perspective, if you cannot feel literally what they're feeling, you are in the wrong business. Go someplace else and do something different. Because this is not the place you need to be in. This is not what you should be doing. And we see that from time to time. And sometimes I'll see it because I work at other places, and I'll pull that person aside and literally tell them, you're in the wrong business. You were not here for our patients. Go somewhere else and do something different. Because this is not where you need to be, and this is not what you need to be doing.
And that's good for the patients, and probably the best advice for that person too, right?
Well, I think so.
Yeah.
If I can see it,
good for
and
you.
I've been doing this, 28 years now, it's go do something else.
Yeah, good for
This
you.
is not your line of work.
Rena.
One of the stories that occurred to me as Alan was speaking was something that happened recently. I also share my phone number with my patients. I treat pulmonary hypertension on the outpatient side, so many of my patients are on continuous IV therapy even when they're outpatients, and I need to be immediately accessible. But I was home, it was 5:30, it was that sort of hour where you're trying to do everything, right? Like dinner, homework, be interested in your kid's day, think about all the things you didn't accomplish at work and berate yourself and the next day. And I usually do that when I'm drinking wine because that helps. So my phone buzzed, and in my head I was thinking, is that a page? It was another thing to attend to, right? I felt the pressure of what that could be. And I looked at it, and it was a picture of a high school music concert. And it was one of my patients who had survived lung cancer, and she had texted me, "Thank you for another concert. It sounds like heaven." And it was this moment where, I realized, yes, when you open yourself up to be the recipient of everything, you're also opening yourself up to these gifts that can come your way too. And that if I didn't have that open channel, I wouldn't know that when my patients are in the world experiencing something that's beautiful for them, they want to thank me for it and let me be a part of it. And it just felt like the best gift.
Yeah. And it's interesting on so many levels, and maybe you can relate. I think about email and text messaging and all of this impersonal stuff as a way of just getting in the way of relationships, but actually they create a new means of connecting with your patient, right? And maybe it's a digital way of sitting around that table and having cookie and milk and your dad listening to the family members. There is some good there, I think, right, Brenna?
Yeah.
And I think it's interesting. If I could just share another little anecdote. If patients know that you care, and like Victor said, you can't fool them. If they know you care, that goes so far. I'm going to give you a story. On Sunday, I work 2 Sundays a month, and we have to see all the patients from the whole Cleveland Clinic enterprise because there's only a couple of us working. So I saw, again, a patient that I didn't know, and she came in with a rash, and I was not sure what the rash was. And I told the mom, I don't know what's going on. Let's watch it and see what happens. So I called her the next day on a Monday. She was shocked. I called her to find out how it was. Well, it wasn't better and wasn't worse. Then I called her Tuesday to find out how it was in the morning. And she goes, well, maybe it's getting a little better. But she goes, Dr. Rosenthal, I just don't know what it is. And I don't remember if I said that makes 2 of us or I just thought it. But, and then I called her one more time on Wednesday morning and asked her. And she said, yeah, something's not right. I said, well, let's give it another day and we'll see. If it's not better, we'll figure out another game plan. And then she called me Thursday, or I called her Thursday, and she goes, I want you to know you missed the diagnosis. I go, well, tell me what it was. She goes, well, it was perianal strep. So it's a strep rash in the anal region. They cultured it and it was strep. And I'm pretty sure it wasn't there when I saw it, but maybe I did miss it. It was perianal strep. She goes, so you missed it. I go, yeah. I go, geez, I'm so glad you got it taken care of. She goes, I want to ask you a question. I go, what? She goes, may I transfer my 4 children to you as a pediatrician? I go, you want to come to me? I just blew the diagnosis. I go, you really want to come to me? And she goes, I've never had a doctor that cared like that. So she goes, yeah, you might have missed this one. She goes, don't miss too many more. She goes, but I want to bring my whole family to you. So if I was writing a book, that chapter would be called Missed the Diagnosis, Gained a Patient. So if you care, good things can happen.
That's good. And
It's that expression, and patients don't care what you know until they know that you care.
That's a great, that's such a great,
Did you all hear that?
Say that. That's
Joyce?
such a great point.
That patients don't care what you know until they know that you care.
This is a remarkable woman. She's my boss. Thank you, Joyce Murphy.
You're
Lynn.
talking about technology, and with Facebook and cell phones now, we friend a lot of our patients friend us on Facebook, I should say, and they leave, and we may never see them again, but we see their trips to Hawaii, we see their weddings, we see their babies born, we see their new puppies, and I love following my patients on Facebook. And people in the ICU are critically ill, and sometimes they're nearly died.
Yeah.
And there's a couple of them that I remain friends with to this day, people that have come into the ICU as a trauma on death's door, and I remember so distinctly where I was and taking care of that patient and nursing them through every single surgery and every little thing that happened. I remember the day that they were on the ventilator and we thought, this is it, we're going to withdraw care, and we said for one last time, give me a thumbs up, and Jamie Finkelstein went like this, and there was not a dry eye in the place. It was amazing. And then now on Facebook we see she finished her degree, she got married, she's having a baby, and these are things that we never forget, but something we talked about in our symposium last year was that patients never forget.
Oh, that's true.
And what a great way that you get to follow the patient and see, and then reinforces, this is why I'm here. And I'm looking at you, Terry, you take care of the little babies. I mean, do you ever see them as they age in life?
Oh, yeah.
Yeah.
They're all part of a big extended family.
Tell us the story of one of them. Come on.
Well, you know, the stories that are wonderful to tell, of course, are the ones who come back every birthday. There's two families who will be here tonight who, you know, have been families that have been important. But there's also the families where there are losses. And to me, it's just as much of a privilege to remain part of their family because you shared the life of their child. And, you know, I dual trained in neurology, so I get all the special patients that have a lot of brain injury. And sometimes people say that must be so hard and so sad and so tragic. And it is. But supporting those families, sharing their journey and holding them up, those words, those beautiful words used, you know, it's just such a privilege. And yes, I still hear about and celebrate the next baby, whether it's by Facebook or by texts, or there's a couple of them that call me Auntie Terry. I mean, there's all sorts of fun things, but you have been there at an incredibly meaningful time in their lives, even if it didn't work out the way we had all hoped and dreamed. And just legitimizing that as a human experience and allowing people to know that you're still there and you still remember and that they matter.
Yeah.
It's such a privilege.
And that makes a difference in their life for the rest of their lives, right? Yeah. You know, Jonathan, one of the things I read in your bio was a phrase that you use, fierce compassion. What do you mean by that?
So we often hear about compassion as this soft and loving and touching and
like you are.
like that. He's soft too. But it's there's a thing called fierce compassion that I had to develop when I was an ER trauma nurse. And fierce compassion is the capacity to limit set when someone's crossing a line that will cause them harm or cause you harm. And it's the capacity to do that in such a way that you don't back down, but they respect that. And so it's that and more. But fierce compassion is it's not the hard part of compassion. It's the fire part of compassion is what I like to think about.
That's what Alan had when he left and, you know,
right, that's
closed all
fierce
his patients
compassion.
and went, that was fierce
Right.
compassion.
I'm shutting down. I'm going because
Right.
this is important. And if I'm going to get fired, come get me.
Yeah.
You know?
Yeah, well, you got a stick.
Right.
You speak softly and carry
That's
a big
right.
stick. Yeah. Or maybe it was fierce compassion. I thought you were going to say, Lynn, when the nurse said to Alan, bucko. Come on, you got to pay. You know. That's fierce compassion, too.
Yeah.
So give us an example. Can you think of something?
I'm trying to think. There was a woman who came in who was a psychiatric patient. And she came in and thought she was pregnant. I didn't know she was a psychiatric patient. I just knew she was a woman who thought she was pregnant. We got to banter. She was a vet. And we got to talk. And she said, you know, I stopped taking my medicine because I'm pregnant. And I said, all right, cool. I said, but let's check it out. So we did. And we did a urine test on her. And when the urine test came back, she blew up because she wasn't pregnant. And when she blew up, that escalated into, I was working busy taking care of 4 other patients down the hall. I look around the hallway and I see 2 cops in there with their batons out, and I walk in the room and she's got an IV pole like she's going to wail and take some people down. And I hear my doc yell, we need to sedate her. And I looked, and I developed a rapport with her, and she overheard what he said. We got to give her Haldol, and she started screaming. You're not going to do that. They did that to me in the military. You're not going to do that to me. So I walked into the room, and I had to make a split decision. And I looked at the cops, and I said, you guys are not de-escalating the situation with your batons out. So I want you out of here. And they're like, what? And I said, no, you step out. And I'll be in the room, and I'm okay. I'm going to be, and, you don't lock yourself in a room with a psychiatric patient, so I didn't. So I kept the door open, but I did go in. She trusted me. We had a rapport. And I told her, I sat down with her and explained, and someone was going to get the meds, and I'm like, don't get the meds. And I went out and talked to my doc, and I said, we're not going to give that to her. You give me 5 minutes, and I'll walk out hand in hand with her, the ER, and I'll get her where she needs to be. Give me 5 minutes. So I went in, sat down, and told her that we trust these urine tests. And I said, we won't do surgery on you if that urine test is positive. We won't do things to you. So when that doctor told you you're not pregnant, you were totally not pregnant. And I said, the other thing is you were awesome for stopping your meds and trying to protect your baby. That was an awesome move. And so she was able to sit down. I was able to take the IV pole out of her hand. We were able to sit down. I said, you know what? I got to get you out of here. And there's only one way you're getting out. If you walk with me hand in hand and you promise to go home and take your meds, now that you know you're not pregnant. And she said, all right, let's do this. So we walked out. Police are still out there, still have their batons ready to roll. We walk by them hand in hand out of the ER. And I circumvented her being psychiatrically admitted. And it was all about listening. That's fierce compassion.
Listening and taking advantage of a rapport that you developed.
Right. And the rapport can take 2 minutes. It's the trust that we talk about. You know, people see BS when they see it. And if you're not that, every one of us on this panel is genuine, if not anything. And I think that's really the essence of compassion, is being a genuine human being.
Thank you.
I had the pleasure this morning of, I'm sorry.
No, please, Victor, you're first.
I had the pleasure of hanging out with one of my former doctors at the VA, Dr. Malik, moved here from Pittsburgh to Boston, and he was my primary care doctor. And he and I worked closely together, and he's here in Boston now. And after he left, we were assigned a new provider. And a lot of my patients said they only stayed with that new provider because I was going to remain as their nurse. If I wasn't going to be their nurse, they weren't going to go to that new provider. So I had managed to develop over those 3 years a lot of trust with my veterans. So that they did not want to go anywhere else.
Makes you feel good, doesn't it?
Yes, sometimes.
As it should.
Sometimes they can be difficult.
I find that hard to believe. Let's see, Michael, and then Joe, was it? Not bad. Joni is Alan's sister. So Michael and then Joni.
Thank you very much. I loved listening to you. I have my handkerchief nearby. It's really been wonderful. And for someone who's been in medicine a long time, I wanted to reflect on what I heard and what I experienced. When I was a resident, the average survival for acute leukemia was 4 months. And now we look at it as a cure. And there's been these wonderful strides in curing. But if I came from another planet to listen to healthcare here, I would say that the strength of our system, as you describe it, is in caring and comforting and healing everyone. And occasionally, we're lucky to cure someone. So with you as experts in this phase, and in knowing what your patients both need and deserve, I find that you're very fortunate to be on the podium with Eric, who has the ear and the voice of representing the bigger picture of healthcare and through the insurance industry. So might you offer some advice to Eric about not why it's important, because we've heard this, but how we may build a system that places the values that you have, how we could help you do that, and how Eric may echo that voice about caring and healing as our primary core work.
Thanks, Michael.
Can't be about money.
No.
That's what I was gonna
That was
say.
the primary thing.
You know,
It can't be.
Money is the is
And
the
that's the
driver
problem, yep.
of this whole
Mhm.
show.
Right, right.
All right. What else?
I think we have to recognise to care for the caregivers. And I think that often the pressure and the burnout that's being talked about, I mean, these are real aspects, and just replacing the work, force in different areas is so expensive in terms of healthcare costs.
Yeah.
And so being able to provide place, space, support within the healthcare workforce for compassion for the caregivers.
Yeah.
One of my residents who graduated last year, and I asked him, I said, so what are you going to do? Are you going to stay here at the VA? And I said, because we like you. And he said, no. I said, why not?
Yeah.
He said, well, because the costs, quote unquote, are uncontrolled. And I said, well, what do you mean? He says, you guys test for everything, even though clinically on the outside it may not be indicated. But here in the VA, because we want to make sure that we don't leave anything, we test for everything. And he was like, I'm always ordering tests for this, that, and the other that
Right.
sometimes I think is unnecessary.
Interesting.
So, because the VA's approach to healthcare is holistic, I literally, once you come in for that first visit,
Right.
we got you. We're going to do a head-to-toe, front-to-back, roundabout assessment. And we're going to see if you come in for a toothache. We're going to see if there is anything else, any other maladies that you may have, so that we can fix that also. And I think his thing was, on the outside, it's quote unquote a more manageable care. I don't necessarily know or think that's the best way that we need to care for people. Because if you're only focused on this instead of that whole person,
Right.
you may miss this diagnosis. And until it manifests itself, it could have been something that could have been taken care of a long time ago.
Right.
But now we're behind the 8 ball. We're trying to play catch up because we did not do this in the beginning. So again, it's, the driver of healthcare is the cost.
Sounds like you
But-
might be paid fee for service instead of payment for value. I'm sorry, I fell into my HMO mode. No, Victor.
So, I like the approach that the VA takes in terms of healthcare. Frankly, I don't know how we fix healthcare in this country. I really don't know. All I know is it's too expensive.
Well, I think any hospital is like that. I know the ICU is. Say, we haven't tested this well. Order a bunch of labs. Order this. Order that. Don't even think about it. Nurses don't think about the cost. Doctors don't. And think about that. That's an extra, $200,000 cost. Let's get a CAT scan, an MRI. Let's do this. That hurts. We'll do that. We'll get another, with and without contrast.
And the beauty of what you all have been talking about in the last hour, though, is that's important, the technology, the labs, the medicines. But what I hear is substantially important is how you deliver the care, how you establish the relationship with your patient. It's that compassion. And no matter what the healthcare system changes are, what I'm hearing is that's the one piece that needs to be propped up.
Well, Yeah,
process.
exactly.
Deal with all the other utilization costs, et cetera, but don't lose sight of compassion. Expand it.
Well, we've got to take care of ourselves.
Yeah.
And Ellen mentioned that we have a broken system, and the work that we do, the resilient focus, and what is the answer to resiliency? Is it mindfulness? That's one aspect.
Yeah.
Is it laughter? That's another aspect. Is it play? There's another aspect. But it's how do we take care of caregivers so that they have longevity?
Yep.
They're inspired to do the work. They can shut down their clinic for a half a day to go and relay information and be willing to do that. That's the rub. And there is no one answer to that.
Yep.
But we have a lot of people fighting to do that because we have a lot of people crying to have it happen.
Yep. Well, what I would say is this. First of all, I'm getting this signal, and I know there's many more questions here, and we've got a wonderful 2-hour reception set for more questions and discussion. But my takeaway here is I can't agree more with what you just said, Jonathan and others. You all, we need you to be our educators, and don't stop doing what you're doing. Share your life lessons to others. One sentence changes the lives of a patient, their caregiver, or a fellow colleague. And we thank you. We thank you for what you do. We thank you for being here and sharing a very personal part of each of you. Can I ask all of you to join me and say thank you?